Okay, so my name is Elizabeth, and I'm going to be talking about ALS and the roles of an SLP. So I know everybody pretty much knows what ALS is that's in this room, but just a quick refresher on ALS. It stands for amyotrophic lateral sclerosis. It is a progressive neurodegenerative disease that affects nerve cells in the brain and the spinal cord. Amyotrophic means no muscle nourishment. Lateral refers to the areas of the spinal cord that contain the nerves that send the signals to the muscles, and sclerosis refers to the hardening in the region. So basically what happens with this is there's progressive degeneration of the motor neurons, and when these die off, the brain loses its ability to control voluntary muscle movement, such as eating, speaking, things like that. But with ALS, people lose their ability to speak, swallow, eat, move, and finally breathe. There's two types of ALS. The first one is limb onset, and then we also have bulbar ALS. Limb onset ALS is what most people think of when they do think of ALS. There aren't, unless you're in the medical setting, most people don't realize that there are two types. But the symptoms first occur in the arms and the legs. And some of these symptoms include tripping, muscle weaknesses, having abnormal fatigue of their arms and legs, and then also having things like muscle cramps. And then some people also experience uncontrollable laughing and or crying. With bulbar ALS, it starts in the corticobulbar area of the brainstem, and this type of ALS also has a quicker disease progression compared to limb onset ALS, and it also has a decreased life expectancy. The first symptoms present as issues with the tongue, but at least when some people come in and they don't have a diagnosis of ALS yet, they will have issues with swallowing or speech, and then, as it progresses and as there becomes an ALS diagnosis, it all goes back to weakness in the tongue. And this is also, bulbar ALS also has a lot to do with the tongue fasciculations as well. So ALS obviously impacts people's speech. Muscles become weak and or tight. So mixed dysarthria is super common. And of course, this includes things like imprecise articulation and consonants, impaired loudness control. People sometimes have a hypernasal voice quality, and also slurred speech is really common. Weakened lung muscles also have an effect on their breath control, and speaking can cause a lot of fatigue in people with ALS. One thing that a lot of people with ALS do use is an AAC device, and I'll touch on this a little bit more. The impact on swallowing with ALS. So obviously, swallowing requires tons of muscles to work together to create a safe and efficient swallow. ALS weakens these muscles, so of course the entire swallow is going to be weak. ALS causes dysphagia because of these weakened muscles in the mouth and the throat, and the symptoms in ALS with dysphagia come across as coughing, feeling like food and liquids are stuck in their throat, having poor oral control, and also just having an untimely swallow. Pneumonia happens a lot with dysphagia in people with ALS just because they're obviously at an increased risk because of their dysphagia symptoms, the weakened muscles. Pneumonia can be very common. And then that, of course, can cause other health issues because people with ALS are already pretty sick. So pneumonia is never good, especially in this case. Dysphagia occurs in an estimated 85% of individuals with ALS. So in the speech world, we especially see a lot of this. Okay, and then I have a few little diagrams on here. And these are also on the handout that you guys all have. But again, just common symptoms of ALS, some that I didn't include earlier. Digestive issues, cognitive impairment, and anxiety and depression. ALS also is in 4 stages, so you have early stage, middle stage, late stage, and end stage. Early stage starts off with trouble like buttoning your clothes, grabbing things, small items like that. You can also have balance problems. People start tripping more frequently. People start noticing swallowing problems or speech problems, and people have muscle twitching and cramping that they wouldn't normally have. Middle stage ALS is when some muscles can become paralyzed. Walkers and wheelchairs start to be needed during this stage. People lose their ability to drive, and people start displaying breathing problems. Late stage ALS, mobility is super limited, and a lot of people require a feeding tube at this point. They're not able to communicate without assistance, and the breathing is severely impaired at this point. End stage ALS is the fourth stage. This includes paralysis of voluntary muscles, and the respiratory complications are super common, and that is ultimately what leads to death in ALS. And hospice care is necessary at this point. So the role of the SLP in treating patients with ALS, we have to make sure that we consider factors such as disease severity, expected progression of the disease, cultural consideration, outside support, and the patient's goals and what they want for their quality of life. So I looked at a study by Rogus, Paglia, and Plomin, and patients that get patient-centered care from the beginning of their diagnosis will experience an improved quality of life for a longer time compared to those that do not receive this type of care. And what I'm talking about whenever I say patient-centered care is care that really focuses on what the patient wants, listening and validating the patient, and really hearing what their goals are. Not every patient is going to want to do the same treatment that you think you would do for yourself or that you think that they should do. So we have to be really careful of that and really make sure that we are listening to our patients with what they want and their goals for themselves, as well as, looking into everything with their disease progression and also talking to their family, getting to know them, and really understanding what they're going through as best we can. As SLPs, we're responsible for understanding ALS and really understand the impacts on speech and swallowing, so we can do a better job treating the patient as well as counseling them and being there for the emotional support side of speech therapy. Counseling and speech pathology. So neurodegenerative diseases such as ALS can take an emotional toll on patients as well as their family and caregivers. According to ASHA, SLPs counsel by providing education, guidance, and support, so we play a major role in patient care through counseling and not only just the treatment of speech and swallowing problems. So SLPs can help with the emotional side of the diagnosis, and we can provide some of that support, but we also are able to refer to other services such as counseling, therapy, things like that, if they want to, but we can offer that as an option as well. And the most important thing when it comes to counseling our patients is knowing our patient. So a quick example that me and my supervisor, Cindy, dealt with this semester, we had a patient that was not diagnosed with ALS when they first started coming in to see us for outpatient therapy. She was having swallowing troubles and speaking difficulty. She had slurred speech. She was just having a lot of issues with that. She was unsure if it was ALS. She was waiting to get tested at the UAB clinic in Alabama. But she had been doing her research. She knew what was going on. And she had looked into ALS a lot. She finally came back a few weeks later after visiting UAB and did receive an ALS diagnosis. And with this is kind of when counseling and really knowing your patient comes into play with speech. But she was the type of person that was wanted to work. She, wasn't super emotional or didn't want to get emotional. And she was totally good just coming into speech, doing what she needed to do, and being done. So obviously we knew about the diagnosis. She emailed us when she got that. So we were aware before she came in for one of her speech sessions. She was very to the point, was very okay, it's ALS, what do we need to do? What can I do? We educated her, talked about her diagnosis. We did a lot of counseling in terms of educating her and giving her resources. And then after that, she emailed us a few weeks later and wanted to discontinue her speech treatments, and we were fine with that, but that was her choice. We had given her options, you know, with AAC devices and like little apps on her phone. She had compensatory strategies. She used thickened water, so she was prepared, but she also was like wanting to just live her life, felt that she could go without speech for now, and if she really needed it, she would do that when she had to. But, you know, we educated her and she felt that she could make that decision and that was necessary for her. And then just to quickly touch on patient needs, I looked at another study that was done by Hune, and in this study, they looked at patient-centered services in ALS treatment, and there were a lot of patients that stated the loss of their communication abilities was the most devastating part of having ALS. And the study also looked into how patients and their caregivers were wanting more support when it came to dealing with communication and swallowing needs at home and in general. So they talked about things like bulbar symptoms and the management of those, feeding tubes, palliative care, and AAC devices. And if we have a limited understanding of the patient, this means that we are not able to really dive into their diagnosis and we're not able to really learn about them and get to know them, and this can also decrease their willingness to participate in speech therapy and engage in other services like counseling, occupational therapy, physical therapy, whatever they need. With the AAC, some people struggle with this because they feel like, you know, they might be losing their voice, and even though it might be what we think is the best option for them to use, like if they're having trouble communicating at home, they might not want anything to do with it because to them that's not who they are, or, you know, they might just be doing okay with what they have at home and how they're communicating with their partners or caregivers. So it's really just up to the patient, and we really need to lean into them and listen and respect and value what they want, because ultimately it is their life and their quality of life. So while we obviously have evidence-based practice and the research and the skills and the knowledge, we also have the patient who ultimately tells us how they kind of want to go about their diagnosis and their treatment throughout the course of ALS. So yeah, that's all that I have.